Good afternoon, everyone, or almost afternoon. We're just a few minutes away from starting. This is Mary Megliola-Franzen from HealthierHere. Folks are slowly logging in, maybe sitting down with their lunches, so we're going to get started just a minute or two after the hour. Glad you can join us today. Hello again. Good afternoon, everyone, and welcome to the HealthierHere Partner Learning Webinar. This is the second Partner Learning Webinar we've had this fall. Today we have an introduction to population health and use of registries to improve outcomes for your patients. I am Mary Megliola-Franzen, a project manager here at HealthierHere, and next to me is Tavish Donahue, also a project manager.
Hello.
She is going to be monitoring chat as we go along today. We're asking you to chat in your questions, so I'm going to ask her just a moment to explain the best way to do this.
Next slide.
Is it not? There we go.
Okay, so what you see on the screen is a visual of what you see on your screen, kind of as a sidebar.
Louder.
So it's actually not chat. You will see a panel called questions. So that orange arrow at the bottom, if you have a question for us, please type it in. I am the only one who will see that. And we are going to hold questions to the end. So when we get to the end of our time today, a little bit before 1 o'clock, I will be kind of reading out the questions and our panelists will be addressing them. There's also a way to speak your question if you would like. Next slide. So these are the logistics about speaking. If you join the webinar solely on your computer, you are good. You would just raise your hand with the hand symbol, and then I will unmute you, and you can speak your question. However, if you have dialed in from a phone, you need to make sure you enter an audio PIN. You can see an explanation of where to see your audio PIN. It's under the audio tab of your sidebar. So if you don't enter that audio PIN, and if you've joined on phone, I won't be able to unmute you. So if you would like to speak your question when we get to the end, please make sure you take care of that. So again, the process, to speak a question, raise your hand, and I will unmute you so you can talk.
Are we good?
We are.
All right. Thanks, Tavish. And I think as Tavish mentioned, We will be gathering up questions and keeping track of questions, but addressing them at the end of the presentation. And as I said, we have two presenters today. We have Dr. Jeff Hummel and we have Michelle Glatt. Dr. Hummel is the Medical Director for Healthcare Informatics at Qualys Health. He's a general internist who began his career practicing in rural Eastern Washington near the Idaho border. Also practiced in Seattle at Group Health. He currently focuses his efforts on applying quality improvement methodology to a population health perspective in ways that cut across clinical boundaries to include conditions such as chronic disease, opioid use disorder, and the integration of behavioral and oral health into medical practice. Our other speaker is Michelle Glatt, who's the Vice President of Population Health at HealthPoint. Michelle is a certified physician's assistant. She practiced in the Seattle area in a community health center, and then she pursued a master's in public health and turned her attention to healthcare IT, quality improvement, and patient-centered medical home consulting. She's also worked internationally. She was the Director of Programming for a community health worker program in rural Peru. She returned to Seattle in 2017. Early 2017, she joined HealthPoint. So now I'm going to turn it over to Jeff, who will get us started.
Thank you, Mary. When Mary contacted me at the beginning and asked me to put together the content for this webinar, she told me that the audience would be both behavioral health and primary care and community-based organizations, and it would include people who are both expert in registries and population health and those who were thinking about it for the first time. So recognizing that this was an impossible task to meet the needs of the audience, the first person I thought of to help me with it was Michelle Glatt, who I've worked with at Qualys Health and is an old friend and colleague. So what we're going to do is take you through kind of a both a high and low level tour of population health and focus in on registries. And by the end of this session, hopefully you'll come out of this with an understanding of the essential role that registries play in population management and some idea of the tools that are available for creating registries, and then who uses them, what does a registry look like, who uses them, and how are they used for population management. So to get us started, I'm going to turn this over to Michelle to give us kind of an introduction or an overview of population health.
Hi, thank you, Jeff. So this is Michelle Glatt, and I'm hoping that everybody can hear me.
Yes, we hear you fine.
Perfect. Okay. So I wanted to talk a little bit about why we're talking about population health in the first place. Population health is in the title of what I do, and so I get asked a lot about what population is. And the truth is, it's kind of just what it sounds like. It's monitoring the health of an entire population rather than a single client. But I think the real question that people are asking is, why are we talking so much about population health right now? And, I think the answer is, in 2008, the U.S. was really starting to grapple with this concept that the amount we were spending on healthcare wasn't necessarily buying us better quality and better outcomes. And so the Institute for Healthcare Improvement actually came up with something called the triple aim, which I'm sure many of you are familiar with. And it eventually became the quadruple aim, which I'll get to in a minute. But it's this idea that you have to balance these three things simultaneously. You have to balance per capita costs, the patient experience of care, which includes quality and safety, and then the health of the population, or population health, and thus the phrase population health was born. At some point, some very smart people said, you can do all three of those things and balance all three of those things, and if your care team burns out and leaves and sets up a flower shop someplace, you actually aren't improving healthcare either. So it became the triple aim, which I think is very appropriate. And through that, we started talking about things like high value care, and so value-based purchasing and things like that. Those terms came from that. So that's why we talk about population health, because it's right there at the top of the triple aim. Next slide. So the first step for population health is defining the population, and this is where we really get to registries. So these are questions like, who are the patients that we're going to define our population by? Which communities do they come from? What barriers to health might they have? What health conditions might they need treatment for? And what services might they need to maintain for optimal health? And once you get into those questions and you've defined members of your population that way, you've essentially built yourself a patient registry, which is kind of what this webinar is about. So next slide. So the thing that I wanted to say before Jeff got started on his really excellent discussion of registries is that the one way that we don't define population health or the population as population health professionals is by the folks that just come into our organization that day. It isn't, population health is really about defining the entire population, including those that are not there, because the most vulnerable people in our communities are probably not right on time for their A1C test. They're probably not the ones that are picking up their antidepressant medications every month right on time. So the most vulnerable people in our communities have multiple competing priorities, and if we don't keep track of them and build registries to sort of track them over time and build programs that make accessing care easy for them, and potentially even remind them about the next step in their care, at least occasionally, then we're kind of missing an opportunity to help that population. So with that said, I'm going to turn this back over to Jeff so he can talk a little bit more about that tool, the patient registry, which is sort of a foundational step for most population health.
Thank you, Michelle. I think that sets the stage very nicely for just talking about registries. And what we're going to do, here's what I'd like to spend the next maybe 30 minutes or so talking about. What is a registry? What are registries used for? Who uses a registry? And when is it used? I think Michelle's given us a kind of a good idea of why we need to start thinking about registries. Although I think for some providers, and we'll get to this in a little bit, it may seem like a lot of extra work, and what's the gain? And I think if there's a single answer, it's to keep people from falling through the cracks, is what I heard Michelle saying. It's not the people who come through the door. So what is a registry? A registry basically is a list of every person in a specific population. And we're going to talk about how you define a specific population in a moment. But it's an actual list of people. It's not just, well, there are all these people with this disease and that's our population. We actually have to be able to see the list. And in addition to that, we want to include in the registry key information about the care of that person that's going to help us tell whether we're doing our job in taking care of that member of the population. And what that key information is will depend on what the population that we're talking about is. So you'll see as we get into some examples. What a registry is used for is it's an action item generator. It basically is a way that the team figures out what it needs to do to close care gaps. So it's very action oriented. This is not just to look at and say, oh this is our population, but we need to take action to make sure that care gaps get closed. So who uses it? Well, when I first started using a registry back at Group Health in the mid-90s, it was actually the clinicians who got most excited about it, and they wanted to do it themselves. At least the ones who, like me, who really thought that registries were a great tool. But as we become more sophisticated in our approach and realize that there's far more work to take care of a population than an individual clinician can do, it's very much a team effort, and there's usually a team member that is assigned to working the registry. This may be a medical assistant for some conditions, but most commonly it's a care manager, or in the case of a high-risk population or a high-needs, high-cost population, it may be a case manager. And when is the registry used? At some interval. It might be on a daily basis by the team to look at people coming in for care that day, but more importantly, so that you could close care gaps. And more importantly, it's say on a weekly basis to identify people who are not coming into the clinic that we want to reach out to. So the importance of this is it allows us to see the key healthcare parameters for an entire population in a single view. And that then gets to this ability to manage those outcomes that Michelle was talking about, both the quality outcomes and the cost outcomes. Because if we're going to manage that care, we've got to be able to see the care gaps you manage a population by closing care gaps in individuals, one gap at a time, and this allows us to prioritize those and do that in the course of our daily workflow. And of course, the goal here, if we're going to reduce costs and improve outcomes, two ways to measure that are keeping people out of the hospital when it's avoidable, or out of the ED when it's a hospital, or I mean, sorry, when it's avoidable, and that is clearly in the best interest of the patient, and it reduced costs. So here is a picture of a registry. Now, I made this one up. And it actually has, so there's no data in it per se, but it gives you an idea of what a registry looks like in its simplest form. And by that I mean, when we first turned on the diabetes registries at Group Health, and I forget whether it was in 1995 or somewhere thereabouts, when the first computer showed up on the desktops of the providers, it was long before there was an EHR. All there was the diabetes registry. And it looked like this. Now, this is not a diabetes registry. This is actually an opioid registry. This is a registry for chronic opioid therapy, so for patients that are getting prescriptions of opioids from a practice, and we want to keep track of them, and we want to use the 6 building blocks approach here. So what you see is down the left-hand 2 columns, the first and last names of the patient, date of birth, and an identifier. You might want the phone number in there so you could reach out to people. So that's not here, but we could easily add it. And then across the top are the sorts of things that came out of the LEAP study that Michael Parchman and Laura Mae Baldwin published in their 6 pillars, or I mean the 6 building blocks paper that is being widely used for office practice of opioids. And what you see here is, so the date that there was a scheduled or a controlled substance agreement signed most recently, the date of the most recent office visit and most recent contact, when the prescription drug monitoring program was last looked at for this patient, when the last time a morphine dose equivalent was documented and what that morphine dose equivalent was, what if the last time you assessed the patient for their readiness for medication-assisted therapy, and what the patient's response was, and the last time that they had random urine testing. So this is the type of information that can give you a very quick view of not the people coming in on a monthly basis that are just fine, but the people who you see red. So for example, the second line, someone who's overdue for everything and their morphine equivalent, or the morphine dose equivalent is over 90. This person is someone you definitely want to reach out to because they are at high risk of having an adverse drug event. And the same is true of the patients further on down. And the idea here is that you close these care gaps one at a time and you improve your outcomes. So how do we do this? How do we actually make this happen? Because you can't just turn on a registry. The registry doesn't magically appear. And the first question you have to ask yourself is, what are the data definitions to define a target population? We can say people on opioids, or we can say people with diabetes, but if we're going to actually generate a list, we have to go into the EHR, which means we have to be able to define those people in some sort of a data query format. And that sort of helps us, of course, what allows, and not only identifying the people, but those the aspects of the care that we want to be able to monitor. We have to have a data definition for those. So clearly we need to have demographic data. Some populations will be defined by age and gender. So I'll show you some examples of that in a moment, but a good example might be children from 0 to 5 who you're going to do some sort of an oral health intervention to reduce caries prevalence. And so that's an age. Gender would be if you were going to do a registry on women of childbearing years for something that you were going to do for them. Most health conditions that include a diagnosis like diabetes, the problem list serves as a really good kind of on-off switch. If they have diabetes on the problem list, then they go in the registry, and if they don't, they don't. There are other populations, though, such as warfarin, which is a good example that you can't necessarily use a problem list entry, and so it's a combination of prescriptions and perhaps lab tests. There are other populations used for, let's say, care transitions, in which you may have a population, you want to have a registry of everybody who's been admitted to the hospital, and what you want to do for that population is a very systematic assessment of the social determinants of health to make sure that people who are either are homeless or at high risk for homelessness have an intervention started while they're in the hospital to make sure that you reduce their risk of a readmission. And that might be a registry that is triggered. They go into the registry with the admission event, and then as they're discharged, that gets them off the registry because the work better have been done by then. But so the important thing is to pay attention not only to what gets you onto the registry, but also what gets you off the registry. So here's just kind of to elaborate on that a little bit more. This shows you a list down the side on the left of different types of things that certainly I've been involved in making registries for, with depression, diabetes. I'll show you anticoagulation in a moment. I already mentioned children 0 to 5. And an example of what you might use for getting them into the getting them into the population, such as diagnosis code. In the case of depression, it might be people with a PHQ-9 over greater or equal to 10. For pregnant women, if suppose you're doing oral health, you want to make sure that everybody gets their periodontal tissue examined. It might be the first prenatal visit that gets them in. We've already talked about discharge planning. If you're looking for a high need, high cost population, you might start with looking at people who've had a certain number of ED visits within the year. The point is, each of those has a different length of time in the population. It may be very long term, it may be limited to the episode of care, or it may be very quick, as we talked about with discharge planning, and then leaving the population. It may be the only way you get out of the population in a case like, let's say, cognitive impairment or diabetes, is you either leave the practice or the patient is deceased. But in others, there may be some sort of patient choice involved. I can imagine for depression, for example, even though the PHQ-9 may come down, it may involve a discussion with the patient. Is this something that we can sort of back off on, or is this somebody who's very fragile who needs to kind of be hovered over? And for if you're watching pregnant women, you might want to then use the first postpartum visit. So this is an example of how we use data definitions to define the population. How do you actually turn those data definitions into a registry? And there's a lot of ways to do it. I showed you a very primitive one, the example that I alluded to, our experience at Group Health when all we had was an Excel spreadsheet. Those fields were not entered by hand. Those actually came out of a data pull from the giant Group Health database, or multiple databases. This is back in the 90s. But you could, in a small practice, you could easily set up an Excel spreadsheet that you were actually entering the data by hand. Now, easily is in the eye of the beholder, obviously. It involves work. But if that's your only tool, then it may be worth it to do that. What's nice is that many of the EHRs have what we call a patient list functionality, where you can actually list all the patients who have a particular diagnosis. So in the case of depression, on the problem list, or diabetes, you could generate a list of all those patients. It may not include all of the variables you want in your registry, and those might have to be entered by hand, but it could be done. In fact, all EHRs that are Meaningful Use certified have canned reports for some of the QPP measures, and so you could use those as well if they allow you to do more than just numerators and denominators, and most of those allow you to drop it into Excel. The best, or let's put it this way, the technologically most robust way to do it is either queries that you run out of your EHR database, if you're a large enough organization to have an IT shop and a reporting database, and you can prioritize it, and you've got the skills to do it, then you can start creating queries that will create what we would call registry functionality that will give you exactly the same sort of picture, and it might be even more user-friendly. To fill the void, however, there's been a whole bunch of third-party registry vendors that have appeared in the last several years. Some of them are, they cost. And the question is it worth it or not? We've steered people towards the PrimeMD one that has been, that there's a partnership with the American Academy of family practice, but again, these don't run for free, but they do allow you to start to use your EHR as a registry. But the right way to do it depends on what technology you have available to you, what skills you have in your IT shop, and of course the cost. Now, conceptually, what we're doing here, and this really ties back to what Michelle was talking about in terms of using the registry to manage the population. I find it very useful to just boil things down to very simple concepts. And this is one that came out of one of our oral health population efforts. And the first question you have to ask is, who's in the target population? And we've just spent a lot of time talking about that. The next question is, who have we assessed? And usually there's a time frame on that. So for diabetes, we oftentimes say we have to have done something within a year, such as dilated retinal exam or something like that. And then the question is, what did we find? Because if you're assessing, you're really looking for something, and what did you find? And that's going to be the prevalence of that condition within, and it may be, so using a different example, if your target population is people with heart disease, and who have you assessed, who have we even checked their blood pressure on in the last year? And what did we find is, did we find the people whose blood pressure was too high? And then the question is, what did we do? And you'll see the care, there are two kinds of care gaps. There's the care gap between who's in the target population, who we've assessed. So that's one of your first things, to reach out to people and bring them in to assess them. And then the question is, when you found something, did you do something about it? Now, the example down the left-hand side, I've sort of stuck with the opioid model here. So one way of defining the population for a chronic opioid therapy might be who has the ICD-10 code for opioid use disorder, or chronic opioid therapy, I guess it would be, on the problem list. And then we oftentimes will use, I think it was Michelle that introduced the term, to me at least, of complementary reports, where you have some other way of looking to see, is there someone who, say, has had 2 or more opioid refills within the last 90 days, but we didn't bother to put the F11 code on their problem list. So you need some way to make sure that your problem list accurately reflects what's in the chart. But then the question is, did you document all these things at the last visit that we saw on that spreadsheet registry example that I showed you? And these are things like in addition to the morphine dose equivalent, you might have the PEG score for the pain enjoyment general activity score and things like this. And then you want to find the people. What did you find is the people who, let's say, who have a very high morphine dose equivalent, or are on a sedative hypnotic at the same time, or maybe who've had a fall or a near fall in the last year or something like that. And then, now, one important thing about it is, we know that what you do when you find a problem that needs to be solved is a clinical decision, and we oftentimes cannot build that into our protocols. We can't say that just because a person has a particular score on their PHQ-9 that they should all be put on a particular drug at a particular dose. Or they should be put on a drug at all. Those are clinical decisions, and they depend on clinical judgment, on comorbidities, on things like cultural aspects and patient shared decision making. So we have to leave a lot of that up to the actual clinical context. But what we can do is make sure that whatever was done, whatever the clinical decision to close that gap was, that it was effective, which means we need to have some way of documenting that there was follow-up, whether it was a visit or a phone call, and so that the next step in step care can happen. So that kind of is how we use registries to track improvement and to report. So the line between the use of a registry to reach out and change the care of patients and improve the care, and our reporting on it starts to get blurred here when we think of the care gap as being that difference between, the care gap one as being the difference between people who've been assessed, and then the second care gap that I alluded to is the care gap between the people who had a particular thing that we were looking for and those that have been treated or that we're actually intervening on and actively managing to close. So let me show you a real-life example, and this goes way back a number of years to a project that I was involved in sort of creating at the University of Washington, in which we had a situation with our anticoagulation patients that had been being managed by a pharmacist in a centralized way, actually. And what would happen is people come in and get their blood test to see if they were properly anticoagulated, and then the next day the pharmacist would contact the people and tell them what to do when the labs came back. And that all changed in about May of this year of 2004, and we had to basically come up with a new system that involved having the blood tests being done in real time in the clinic with immediate feedback, and then the care teams themselves making an adjustment in the patient's dose before the patient left the clinic. And you have to understand that up until that time, the standard, at least all the evidence was that you did better with a centralized anticoagulation clinic than you did with a decentralized system. But for a bunch of different reasons, that got changed. And so here what you see is we basically tracked the number of people who were on anticoagulation over this period of time. And again, there was no problem list entry. All there was is what we used was people who had the INR test ordered within the past, I think, 3 months, and who had an active prescription written by one of the docs in the clinic. It wasn't just on the med list, it was an actual active prescription order, and that told us that the patient was being managed in our clinic as opposed to, let's say, by cardiology. The next thing we asked is who had been assessed within the past 35 days, and this gives you that graph. So on the beginning of every single month, the question was, of the people in the clinic, of the people in the population on that date, how many had been monitored within a rolling 35-day look back. And as you can see, when the pharmacist left in June, it started to fall. It doesn't look significant in that whole scheme of things, but if you realize that's what happened, you realize there was a downward trend until the new system was turned on in October. And the same thing with the percentage of patients who were monitored in the target range. And you might say, well, this just looks like kind of bouncing around. But in fact, there was this big drop off between May and October, and then the overall curve was up. So this is an example of using a registry to steer change and to manage a population that you might not have started thinking about. But this is gives you an example of the versatility. So with that, what I would like to do is, that's talking about registries, giving kind of an overview of it from the most simple to a more complicated approach to using registries in different types of populations. But what I thought would be useful, given the variation in context for the people who are on this webinar, that we ought to do a bunch of use cases and just give you some real concrete examples. Some of these we've done before. Some of these I will explain are a little bit more that I had to think up, but I didn't do it by myself. The first one is going back to this chronic opioid therapy for population management in primary care. So the setting for this, and this again is in line with the discussion we've already had about chronic opioid therapy, both in terms of that primitive registry that I showed you at the very beginning, and some other slides. Imagine for a moment that you are in a 5-clinic system that's managing patients that are on chronic opioid therapy. These are people who are getting their prescriptions from the clinicians in that clinic. This is not a street drug particular emphasis on this case study. And they're using the 6 building blocks approach that came out of that LEAP study that was published about a year and a half ago that I think a lot of you are familiar with. And if you're not, we can certainly get you the paper. The clinic itself does not, it's not presenting itself as an opioid treatment facility. It's not advertising. It's not seeking out people on opioids. But what they want is order in their own population of chronic opioid therapy patients, because it can be very disruptive to have different ways that different clinicians are managing patients. They also, of course, want to reduce the risk to the patients who are on opioids, and they want to get as many people onto medication-assisted therapy as they can. So they've trained up at least one provider in each clinic on buprenorphine induction and management, and then they're not encouraged, as I say, they're not encouraging referrals from outside, but once induction is complete, they are encouraging the patients to be managed by their own PCPs. And the purpose of the registry then is to manage this population to prevent overdoses and also to reduce stress on the primary care team. So the clinical concept here that we're trying to capture in defining our population is people on chronic opioid therapy. The data definition, and there's a lot of ways to do this. So this is not saying here's what you do so much, but more here's how you do it, or here's how you approach it. So let's say we use that F11 ICD-10 code on the problem list, and then we use multiple opioid refills as our way to identify people who should have that on their list. And we're also, of course, screening for people using the expert screening tool to identify people who may be on opioids that we don't know about. And of course, we can always look in the prescription drug monitoring program, although doing that on people that you don't know are on opioids is probably not going to happen very often. And you'd get people off the registry if they're managed elsewhere, because again, this is the patients that are being managed in this clinic. So there might be a few that are getting their opioids somewhere else. And you get them off by taking you might not want to take the F11 off the problem list. You might want to have a dummy code, let's say, for people who are managed elsewhere, or you might want to, so there's a bunch of ways to handle these problems of people handled elsewhere. But if people are actually come off the opioids altogether and they're no longer taking them, which would be great, you also need to get them off if you're not doing refills in the last 90 days or so. So what information would you include? Well, we've already seen this actually in that spreadsheet, but it's going to include the key points out of the 6 building blocks, things like the controlled substance contract, and contact, either in an office visit or by phone, and the morphine dose equivalent, and the things we've already talked about. Though the important thing is, how is it used? So there has to be someone who is in charge and has the role of chronic disease population manager in the clinic. More and more, we're finding that trying to do this in an individual team leads to the kind of variation across a clinic, which can undermine your ability to get standardized quality outcomes. And it's just more efficient if you have a single chronic disease population manager in your clinic, and that way you can do multiple diseases far more easily. So that would be this person would be following a protocol in closing care gaps, like the ones that we talked about when we looked at that spreadsheet. And they would certainly confer with the care team. They're not going to be operating outside of a care team, but there would be certainly outreach to patients, scheduling follow-up. There may be referral to community-based resources, since there's a lot of ways that interacts with chronic opioid therapy. But the medical assistants will also be using their registry on a daily basis in preparation in their huddle for patients who are on their schedule for the day, because your best chance to close a care gap if a patient's in the clinic is before they leave. Okay? So that kind of is an overview of how we would use a chronic opioid therapy registry in a primary care clinic. Now, I'll make an admission in spirit of full disclosure, in coming up with a behavioral health clinic registry use case, I had to ask for some help because, first of all, I'm not a behavioral health clinician, so that's not a world I've lived in. But I'm also aware through my behavioral health colleagues that it's not uncommon to find people in behavioral health clinics who say, I don't see the purpose of a registry. I'm not sure how it helps me. It seems like more work. We're already getting together for case conferences and talking about the people who we're worried about. How does this help me? And so I actually spent some time on the phone with a number of people in the King County region who work in behavioral health clinics, trying to get an idea of who are some ideas of populations where patients fall through the cracks easily. because I think that is something that every behavioral health clinician can relate to. Who are the people that are falling through the cracks? And one of the, I think, to complement our opioid theme here for this webinar, I set up a use case in which we have a behavioral health agency. They do not have, at the moment, co-located primary care services, although they could. That's something to think about in the future, say hiring a nurse practitioner or physician assistant. They do, however, have a formal agreement with an FQHC that has the capacity for doing medication-assisted therapy for patients with opioid use disorder. But the patients, and they do have, obviously, community-based resources for treatment of other substance use disorders. And so they've got a lot of resources, but the goal here really is to find people who you uncover in your conversations with them. They're in the clinic for different reasons. They didn't come in because of an opioid use disorder. They may be here because of post-traumatic stress disorder or schizophrenia or some other major behavioral health issue and yet the opioid use disorder is a major confounder and a complication of their therapy. And what you want to have is a systematic way that if you uncover it, you have something to do, and number two, that you don't let it fall through the cracks and forget about it. So your data definition might include some way of noting in the chart, I mean, it's going to have to, that they have an opioid use disorder. This may be a positive answer to a screening question on SBIRT or something like this, depending on how you screen for this. And then you'll take it off that patient's problem list or the analogous way that you keep track of comorbidities with the diagnosis code. And then, of course, what you'll want is information such as not only their demographic information, but are they currently using do they have a prescription for naloxone? Are they willing to participate in substance use disorder treatment, including medication therapy? What is their change readiness using the Prochaska model or some other model? And if they are in that action stage, then making sure that they've been referred for an opioid use disorder and that you've got some sort of follow-up to make sure that the referral is completed. And the way that would be used, again, this does require somebody who's overseeing that. And I realize that in many behavioral health agencies, there's not the resource for this, but I think this helps us clarify what resources we need if we're going to do this work as we move into an era where we're going to be receiving capitated or at least some sort of a payment in advance or to cover the population. We can specify what we need to do that and what that will cost. But we're going to be, we want to be identifying people who have substance use disorder in which that needs to be addressed on some way at their next visit, people who don't have naloxone who need it, people who may be ready for, who are due to have their change readiness assessment asked about, and people, again, who are in the contemplative state or the action stage where we may be able to move them along. So that really is, now there are other populations that I think are worth thinking about. I don't think opioid use disorder is the only one. So suicidal ideation is another group that may fall through the cracks. You may be in a setting in which eating disorders tend to come up, and then the patients are being seen for other reasons, but these disorders fall through the cracks, and it would be useful to have those. Or people with self-harming behaviors of some sort. So again, this idea of sort of keeping track of a list and monitoring from time to time to make sure that you're assessing them, and then using validated tools at some interval to see how they're doing. The very last case, I think we'll go very quickly because but it again is related to how behavioral health and primary care interact with each other. And this is the managing of depression in adults with diabetes. This is the one we've actually done, where and again, imagine we're in that a primary care clinic that's part of a larger system, and it's already got a diabetes management program. And you've also got the collaborative care model behavioral health integration as far as having a social worker in that clinic who's part of a behavioral health team that operates out of an affiliated behavioral health group. And so the population is simply those with diabetes, and we do that off the problem list, as we've said. But in addition to looking at the hemoglobin A1C for glycemic control and things like blood pressure, we also say that we want to, and in addition to, let's say, doing dilated retinal exam on a yearly basis, we want to also screen them for depression, because we do know that untreated depression is one of the greatest barriers to being able to manage people with diabetes and improve their outcomes. So they could be screened with a PHQ-2, and then if it's positive, they get the full PHQ-9. If they have a PHQ-9 that's over the greater that or equal to 10, that there is at least a follow-up visit. As we said, you don't know what the right treatment is. It might be talk therapy. It might be let's just wait and see and check back. It might be start a new med. It might be change a dose. It might be refer. But that's a clinical decision. And then, of course, you want to monitor all the other things that you normally do for diabetes. And just to show you, now the care manager would do this as she does everything else on that diabetes, and we don't need to spend a whole lot of time on this, but reach out to those that are due to be checked, make sure that those who had a PHQ-9 that was elevated actually have a follow-up of some sort within a month to make sure that whatever the team did worked, and then reminders about the patients coming in for that day. And this is a flow sheet. This is a run chart, actually, from a clinic up in Mount Vernon, I believe. Up the left-hand side of the y-axis, this is actual patients, not percent. So it's a small clinic, and they only have about 80 total people with diabetes. And you can see the line below, which to me it looks like a dark green. Those who have had a PHQ-2 or a PHQ-9 screen within the past year. And so once the workflow is put in place to do that, you see that start to rise. And then, in fact, they uncovered up to 10% of people in that population who had a PHQ-9 score greater than 10, and now they get to do something about it. So I'm going to stop there because I've been talking way too long, and turn this back over to Michelle to kind of bring us back to how this all fits into the big picture.
Thanks, Jeff. So that was great, and yeah, so I'm going to pull this back up into the big picture a little bit, but the reason why we're looking at this slide again is because I kind of wanted to just highlight that what you just did with those use cases was really define your population in a very clear way. So yes, we're asking questions, who are our patients and clients, but we're defining that population very specifically, and that's how we get to our patient registry. And I kind of want to get into how this patient registry is a foundational step to go in two different directions in terms of population management. So can we go to the next slide? Yeah, so basically, this patient registry, the thing that we were just talking about with all those use case scenarios, is the foundational step for basic population management and also basic quality improvement. They both start out the same way. Essentially, we need to be able to collect the right information. There was a lot of detailed information in those patient registries that Jeff just talked about, and it may or may not be that we are collecting that information in a systematic way. And when we start talking about electronic health records and pulling the data out electronically, if that's where you're at with your organization, we have to collect it in a systematic, structured way so it pulls the same way. And if some people are putting it in another field, we have to think about that a little bit. And so that's important to know, and that changes with time. For example, at my organization right now, we're starting to try to figure out how to collect social determinants of health data in a systematic way. We collect it, but it's free text and it's not very reportable. So how do we get to the point where we can build a patient registry based on social determinants of health? So essentially, they start out the same way. You have to organize the data patient by patient. You have to figure out how you're going to update it, which essentially means how you're going to add new members, and are you going to update it weekly or monthly? And then you can use it two ways. You can use it for the patient outreach and care coordination that Jeff was talking about, but you can use that same list of patients to drive performance once you decide what services, tests, or goals are important to provide the best quality of care for that population. So next slide, yeah. So, and this slide is really, I just want to call out, when we're talking about basic population management and we're building that registry, we're essentially having a conversation as an organization about what we think good care is. So we've kind of evolved past just looking at tests in terms of good care. We also are looking at things like self-management goals, whether we've done the appropriate community and social support linkages, whether or not patients have had medical referrals that have been completed, whether they're getting their follow-ups as recommended. And once we have a conversation as an organization about what the evidence shows and how we want to take care of our patients, then we can roll all of that up into sort of a quality improvement piece. So essentially, Jeff was talking about diabetics, and he was talking about diabetics that should be screened for depression. So once I understand that I need to screen all of my diabetic patients for depression, I can figure out what percentage I'm at right now. So 17% of my total diabetic patients have been screened for depression, and my organization thinks that we should be at maybe closer to 30%. Just knowing that and sharing that data widely across by provider and transparently by provider, by location, across the state, that helps us make workflow changes and systems changes that will lead to quality improvement. But it all starts back with that patient registry. Next slide. So this slide is just here so I can talk a little bit about the stuff that population health people talk about. And I want to emphasize that this is still really essentially registries. So we can define our population in lots of different fancy ways. I talked a little bit about social determinants of health, which is that sort of dark green bubble over there. It might be important for us to understand which of our patients have housing insecurity, food insecurity, and transportation issues. And it might be important for us to put together a registry based on that in combination with other factors. There's another couple of ways that population health folks define their populations, and that's with risk. So there's a lot of risk calculation software out there that can help you figure out which of your subpopulations has the most risk of having complications or ending up in the hospital or the ER. But you don't have to use fancy software to get those risk scores. You can decide as an organization that, say, everybody with 3 chronic conditions and 10 medications is at high risk, because in fact, they probably are. The other way that's been shown to identify subpopulations that are at high risk is to have the care team, pick the patients out that are high risk, because as it turns out, care teams know their patients pretty well, and they're pretty good at figuring out who's at high risk. And once you have that list of high-risk patients, you can build a care management system around that registry and provide wraparound services for those patients. And the last kind of hot topic in terms of population health type things is understanding who your unengaged are. So those are the patients who really aren't coming in. So they're either not getting important, screening tests like cancer screening tests, but more commonly when we talk about the unengaged, we're talking about patients who are assigned to us by an MCO, but they have never been in, they've never established care. So looking at that registry is also important. And for each one of these registries, there's a different set of tasks or programs that you might build to try to improve the care of these patients. And as we get more and more sophisticated, we start to look at smaller and smaller subpopulations. And when we do that, we end up getting really tailored in terms of what those patients need, and we make those incremental improvements. And with that, I think I just want to turn it back over to Jeff to just, sum everything up.
So we have some time for some questions here. And let's see, I think there is a summary slide. Look at this. Okay, so I think what I've been saying and what I've heard Michelle saying is that registries basically can help us, and I think there's a growing acceptance of the model in which we have care managers as part of our team. It allows us, though, to see a target population and the care gaps for that population. But this requires data definitions for membership in the population and for what those care gaps actually look like. And we want to build our I think Michelle said that there's an opportunity to come to an organizational agreement about what we want to consider good care for our patients. And I think we'd all agree that those decisions, although they may differ from group to group, they should all be evidence-based. And so they're going to be kind of a subset maybe of everything you could possibly do, because we can't do everything. But whatever you do decide to do, it should be evidence-based. And then we want to follow up to see whether those care gaps were actually closed. But the flip side of this, or the piece that I think we need to be very, very out front about, is that this requires a population health infrastructure. This isn't something we can't just waltz in and say everybody needs to start doing it using, if they don't have the technology. Now, we can use simple technology, but it's more work. It's to actually enter the things by hand requires someone to do it. And unless there's a way to reimburse for that, it very quickly falls to the wayside. If you have the technology in an IT shop to build complex queries and run a registry like that, it feels automatic to the care team. If you ask them to do it, you'll see it'll grind to a halt fairly quickly. Because it really requires this team approach with someone who's dedicated to the job of maintaining the accuracy in the registry and then using it to reach out to patients to make sure it's translated into those actions. So with that, I want to turn to Tavish and see what questions have come in.
Okay, so we have a few questions that have come in during the presentation. We're going to address those first. If there's any lingering questions out there, please feel free to start typing them in, and then we'll get to those next. And at the end, we will open it up to people who want to raise their hand and speak their questions. So back when we were first talking about the opioid registry in primary care settings, we had a question come in from community psychiatric clinic. So is the opioid registry only used by providers and nurses, or would behavioral health clinicians be able to help too? And the second part of that question, how do you get buy-in across the system to make that possible? Well,
hopefully the perspective of behavioral health and primary care may be the same. In other words, if you have a behavioral health provider based in the primary care clinic, you may very well have a behavioral health person being part of that population management team, assisting all of the primary care teams with their management of the chronic opioid population, and that would be great. Oftentimes what we see, though, is a physical, a non-co-located type of environment where the behavioral health people are working out of a behavioral health agency, and there the perspective will probably be somewhat different. They're not in opposition to each other, and hopefully what I tried to do, and hopefully what came across in the second case study, was some sense of how they may be complementary to each other. So, for example, and I think the collaborative care model is probably the best way to really think of this, so that a primary care practice would be able to, let's say, identify people who are in the chronic opioid therapy population, and if they're being well managed and they've got the dose down, even if you can't get them off the opioids for any number of reasons, those are people that you feel fairly confident about their safety. On the other hand, you're going to have people who you don't, who you're very worried about for whatever reason, and there may be behavioral health issues as part of that, and referral and co-management are clearly going to be the route you want to go, and the more closely groups are working together between behavioral health and primary care, the more smoothly that will go. And then on the flip side, you're going to have a range of different patient types in the behavioral health side. There will be the people who are using street drugs and may simply be, if primary care may not be the best place to manage them. There may be some other community-based organization that will be the best thing to do. But the more we can, the point of registries is that you build the registry to support your own perspective. And again, we have to be thinking more and more in terms of multiple perspectives on these populations. So I hope that helps. Michelle, I'll give you a chance to weigh in on that one too, because you may have a more close to the action perspective than I do.
I think for me, the more the interesting part of the question is the buy-in part of the question. I think that is something we all struggle with, but here's what is true. We're all in it to provide the best care we can, and I think the building of the registry, if we pull in different people to collect the evidence and find out how we can agree upon providing high quality care, I think that building of the registry, so we build a shared vocabulary about what good care is, and that might include a lot of things that we didn't previously think were good care because we're going to do it in a multidisciplinary way. I think that process, I've seen that build buy-in a lot. Once we all agree on the definition of good care, then we start to, want to work that registry a little bit more.
Great, thank you, Michelle. So another question, kind of a logistical question. What happens when someone needs to come off of the registry? Do you keep track of those individuals elsewhere, or do you just delete them and move forward with who stays on the registry?
So the question is, what happens to people when you take them off the registry? Do you have a second registry of people you've taken off the registry? Michelle, I'll let you go with that one first, because I haven't done it that way. I've had an on-off switch, and they're either on or they're off. But I'm curious what you've done.
Yeah, I mean, I think that so I live in a world where we have an electronic health record, so we don't often take people off registry so much as they fall out of the data definition. So, for example, we have some patients that we thought had diabetes, or they got coded at some point as being diabetic, as it turns out they really don't have diabetes. So, we had to resolve their diagnosis, and once we resolve their diagnosis, they fall off that registry. That doesn't mean we don't take good care of them. It just means they don't need that set of services that we built that registry for. So it sort of happens naturally, if that makes sense.
Great.
Okay.
Any other questions?
So far, no. But if anyone wants to speak their question, feel free to click the hand button to raise your hand, and then I will unmute you. Yeah, we'll wait about a minute to see if any other questions come in.
And as we're waiting for folks to raise their hands and ask more questions, I just want to say thank you very, very much to Michelle Glatt and to Jeff Hummel. As Jeff said early on, we came up with kind of an impossible topic, and they did a fantastic job, and thank you all for joining us. And as Tavish said, we'll give it a few minutes to see if any more questions come in.
Okay. Yeah, so far no hands are coming up, and I just wanted to mention we will be sending out the slides after today's presentation, as well as a link to the recording, to the video of today's webinar, so that you can share it with other folks at your organization who might not have been able to participate today. Okay, and it's a little bit after one. Okay, we've got a question. David Newman from Community Psychiatric Clinic. David, we have unmuted you, so please go ahead.
Well, I just wanted to know if we could get a copy of some of the studies referred to.
Interesting, because the studies that I referred to could you be more specific? I showed you data from things that were never published. But the LEAP study, absolutely, what would be the best way for me to send that to you guys? Have you got the LEAP study?
Send it out in our follow-up.
Putting it on the
the LEAP
that
study
sounds good.
Yeah.
Thanks.
And if there's anything else specifically, let the folks here at HealthierHere know, and I'll be happy to dig stuff up for you.
All right, thank you.
Is that the last of our questions?
Yeah, that was it. So we can.
All right, we're wrapping up on time. Thank you all for joining us, and again, thanks to Jeff and to Michelle. See you later.
Very much. Bye-bye.
Thanks.
Thank
Bye.
you.
Thank you.